Extenders, Students, and Scribes, Documentation and Billing Best Practice Guidelines. In this module, we are going to take a look at the utilization of mid-level providers. Specifically, what are the Incident to and Split Shared Service guidelines? We're going to talk about teaching physician guidelines, and then finally we'll wrap things up with scribe guidelines. For Incident to and Split Shared Services, we're going to start here. Incident to can be defined as services or supplies furnished as an integral, although incidental part of the physician's professional service in the course of diagnosis or treatment of an injury or illness. Reimbursement, when billing under Incident to, is based at 100% of the physician's fee schedule, and services provided as Incident to are billed under the physician's provider number. In order to bill services under the Incident to requirements, all of the following elements must be met in order to be able to bill under the Incident to provision. First of all, the non-physician practitioner, so your nurse practitioner or your physician assistant, must be an employee of the physician. Next, the initial visit for that condition must be performed by the physician. This means that you as the physician need to see new patients and/or consultations. There needs to be a direct, personal, professional service furnished by the physician to initiate the course of treatment. There must be direct, personal supervision by the physician. The physician must be physically present in the same office suite and immediately available to render assistance if that becomes necessary. So if you as the physician are in the hospital rounding on inpatients while your nurse practitioner is in the office seeing office patients, then we would meet the requirements under Incident to because you are not directly available to supervise that nurse practitioner. And in those cases, we would have to bill the services under the nurse practitioner's name and NPI. The physician has to have an active part in the ongoing care of the patient. What does that mean? There isn't a set definition of defining what active part in the ongoing care of the patient means. CMS or any other payers that I'm aware of have a rule as to what that means. So at a minimum, I recommend that physicians see the patients at least on an annual basis to check in with them and see how they're going. The place of service is designated as an office place of service or place of service 11. What this means is that every time you bill a claim to the insurance company, there is a place of service code reported on that claim to tell the insurance company the facility setting in which you saw or treated the patient. The most common place of service codes that you will report on physician claims are, of course, place of service 11, which states that you saw the patient in your office, place of service 21, which states that you saw the patient in a hospital inpatient setting, or place of service 22 that states you saw the patient in a hospital outpatient setting. For split shared services, these are defined by Medicare Part B payment policy as a medically necessary encounter with a patient where the physician and a qualified NPP each personally performed a substantive portion of an E&M visit face-to-face with the same patient on the same date of service. A substantive portion of an E&M visit involves all or some portion of the history, exam, or medical decision-making key components of an evaluation and management service. Truly, what defines a substantive portion? This isn't something that we really can say. Medicare hasn't said other than substantive portion needs to be performed and documented. So the definition of substantive portion can actually vary from organization to organization. So it is my recommendation that you reach out to your compliance department and/or coder that's working with you and ask him what is our organization's policy or stance on documentation for split shared services. I'll give you two separate examples. The previous organization that I worked in, we defined as the substantive portion as the physician documenting the entire assessment and plan for that patient encounter. That meant that our nurse practitioner, for example, could see the patient, document the history and exam, and then the physician could come in, see the patient, and document the assessment and plan to that note. We would then take the documentation of the nurse practitioner and the attending and combine them into one final note, and that note together would define what the level of service for that visit would be, and we would bill that visit under the physician's name or NPI. At my current organization, the substantive portion definition is a little bit different. At my current organization, we require the physicians to document a portion of the history, a portion of the exam, and a portion of the assessment and plan. So we want our physicians to contribute to each element of the patient note, if you will, to support billing that service as a split shared service. We would still combine the documentation that was provided by the nurse practitioner and the physician to determine the final overall level of service billed, but you can see that the requirements are different based on the organization that you're working for. Another thing that you need to keep in mind is that the physician and the qualified NPP must be in the same group of practice or employed by the same employer. This is where things can sometimes get a little bit sticky, especially if you're seeing patients in the inpatient setting and wanting to utilize NPP documentation to support your billing. A lot of times, hospitals will have NPPs that are hired to provide 24/7 support and coverage for our patients in those instances where we might not have a physician directly available. If that NPP is hired and employed solely by the hospital entity, and you are an independent physician coming in to see the patient, you must document your own note and cannot attest or use any elements of the note documented by that employed NPPE to support your billing. So please make sure you know, is this nurse practitioner or physician assistant for that matter my employee, or is this nurse practitioner or physician assistant an employee of the hospital? If they are an employee of the hospital, then you cannot use their documentation to support your billing. Some other split shared requirements that you need to keep in mind. First, this applies only to selected settings. So Incident 2 applies solely to the office setting. Split shared requirements apply solely to hospital inpatient, outpatient observation, and emergency department settings. That means that your place of service on claims would either be 21 for hospital inpatient, 22 for hospital outpatient or observation, and 23 for emergency department, which is different from your physician office place of service 11. The Incident 2 criteria must still be met. So what do I mean by that? Number one, it means that the NPP or PA is your employee or an employee of the same medical group. The direct supervision requirements still apply, and the patient relationship is still established, or the treatment for that condition is still established. So you still cannot bill split shared services for a new patient or consultation visit. Critical care services cannot be shared. If you are providing critical care services, documenting and billing, and your nurse practitioner is providing critical care services, documenting and billing, each provider must bill their own service for the critical care time. Procedures cannot be shared. Whoever did the procedure and documented the procedure is the person that will bill for the procedure. Here's a couple examples of split shared services. For example, if the NPP sees a hospital inpatient in the morning and the physician follows with a later face-to-face visit with the patient on the same day, the physician or the NPP may report the service. So in this instance, if the physician documents the substantive portion of the note, again, whatever that is defined as by your organization, then the physician can bill for the visit. If the physician does not document any portion of the note, then the NPP would bill for that visit. Another example. In an outpatient office setting, the NPP performs a portion of an E&M encounter and the physician completes the E&M service. If the Incident 2 requirements are met, meaning that the patient is established or the problem treatment course is established, and the NPP is employed by the physician and direct supervision has been met, then the physician can report the service. If the Incident 2 requirements are not met, meaning that the patient is new, the course of treatment is new, or direct supervision requirements are not met, then the service must be reported under the NPP's PIN. So how can you utilize mid-level providers? There's a couple of different practice models that you can think of. So under the Incident 2 practice model, the NPP sees the patient independently. Again, these are established patients with established courses of treatments. You as the physician would only see the patient when absolutely necessary. And in this case, the NPP would document the service. You are not required to document anything under the Incident 2 model, and then you would still be able to bill for the services. Again, remember, this happens in a physician office, place of setting 11. The patient is not new, the course of treatment is not new, and the NPP is your direct employee. When all those requirements are met, you can bill the services under your name and be reimbursed at 100% of the physician's fee schedule following the Incident 2 practice model. This does help maximize productivity. It can free you up as the patient to see more new patients and consults, and it can also help to open up access in the clinic. Under the split shared model, NPPs always see the patient in conjunction with the physician. Remember, both you as the physician and the NPP must see the patient and document elements of that visit. We typically see shared visit models performed in the hospital, inpatient and outpatient settings. And again, this can maximize productivity. Same thing, freeing you up to see more patients, especially new patients in consultation, and it can help you to spend less time on completing documentation. And again, it's going to depend on your organization's documentation requirements and what is defined as the substantive portion of the medical record. And the last model, and the model that I probably recommend the most because it is the less risky model, is the independent practice model, where the NPP acts completely independent of the physician seeing his or her own patient population. You may utilize this in areas where there are physician shortages. You might have a clinic practice in a rural area, and you might want to bring in a partner, but you're unable to lure in a physician. Maybe you can lure in a nurse practitioner to help you staff this clinic. You can have your own patient population. Your nurse practitioner can have their own patient population. Nurse practitioners can see and bill for new patient visits. They can act pretty similarly to a physician. So in those situations, it's just going to depend on the type of practice you want to set up and who you want to bring in to the practice with you. And the reason that I state that the independent practice model is the least risky of the models is because incident to and split shared guidelines are highly scrutinized by Medicare and open up to audits quite often. And quite often, we also have providers that struggle with getting the guidelines correct and the documentation requirements correct, especially as it relates to split shared services. So that's why I recommend that you let your nurse practitioners see patients independently and just bill direct for the services that they provide. Some direct billing requirements to keep in mind is that Medicare will require NPs and PAs to bill under certain circumstances. So if the NP or PA sees a new patient and documents for the new patient, they will bill for the new patient. If the NP or PA provides surgical services, which could be as simple as an incision and drainage performed in the office, or suture repair performed in the office, those types of things, those have to be billed direct under the NP or the PA. If you have an established patient coming in and that patient has a new complaint or a new diagnosis, you would have to allow your nurse practitioner or PA to bill direct. Because remember, you can only bill incident to or split shared if it is an established problem with an established course of treatment. So established patients under new physician treatment plan, where the plan is altered in a substantial way, those have to be billed direct by the NP or the PA. What is alteration in a substantial way? That can sometimes be a little bit difficult to define. I guess for me, I would define this as completely stopping one medication and starting the patient on a new medication. To me, that would be a substantial alteration in the patient's prescribed course of treatment. In those instances, the NP or PA would have to bill the service under their name. And then, of course, if the services are outside of the scope of practice for the NP or PA, number one, they shouldn't be providing that service. But then number two, ultimately, they can't bill for that service. So you want to make sure that your NPs and PAs only provide services that are within the scope of their practice. Another thing to keep in mind is that the reimbursement for NPs and PAs is 85% of the Medicare allowable. This means that if we bill the service under the name of the NP or the PA, our reimbursement is going to be reduced by 15% of the allowable amount. If we do incident to services and bill the service incident to under the physician's name, then Medicare is going to reimburse us at 100%. This is going to depend on your payer mix, on how you want to set up your practice. If you have a payer mix that is very low in Medicare and Medicaid, you may just want to let your nurse practitioners and PAs have their own independent clinics and bill independently. As we've seen today, most commercial insurance companies will actually reimburse NPPs at 100% of the allowable amount or treat them for reimbursement purposes the same as they would a physician. And then finally, I do just want to mention Medicaid rules are going to vary by state. So if Medicaid is going to reimburse at 100% or a reduced amount on that fee schedule, it's really going to depend on the state Medicaid policies and the state Medicaid reimbursed allowed amounts. So make sure you understand what your state Medicaid rules are. So let's switch gears from incident to and split shared services to the teaching physician guidelines. So some of you, well, all of you now are working in a teaching institution, and some of you, when you move on from residency and fellowship, may end up staying in a teaching physician setting. So if you continue to work in a teaching physician setting, there are certain guidelines that must be met in order for you to bill for the services under the teaching physician rules. And this might actually help answer some of the questions you might have as to why some of your physicians or your attendings act the way they do as it relates to documentation. So let's break this down. CMS sets guidelines and regulations for documentation to support billing for teaching physician services. For purposes of payment, the teaching physician must personally document at least the following: that they personally documented or were physically present for the key or critical portions of the service when performed by the resident, and the participation of the teaching physician in the management of the patient. The documentation completed by both the resident and the teaching physician may then be combined to support the overall Evaluation and Management Service Code build. For E&M services, the resident cannot document the presence of the teaching physician during the service. The teaching physician must document his or her own face-to-face interaction with the patient and the involvement of care. And we'll take a look at what some of these attestation criteria look like. For surgical services, the resident may document the presence of the teaching physician during the critical portions of the service. For minor procedures, the teaching physician must be present for the entire procedure. For major surgical procedures, the teaching physician must be present for the key and critical portions. He or she does not need to be present for the open or close. Let me break that down a little bit. So for minor procedures, these might be things done in the office, such as an incision and drainage or a suture repair, like I mentioned with our nurse practitioners. If these are being done by the resident in the clinic, the teaching physician must be there for the entire procedure, and the resident may document the teaching physician's presence during that entire procedure. For major surgical procedures, the teaching physician must be there for the key or critical portions. Again, they don't have to be there for the open and close. So this means that the resident may prep the patient and do the opening. The attending then comes in and is present for the key portions of that procedure. And once the patient procedure is complete and ready to close up the patient, the teaching physician may exit the room at that time and move on to the next procedure. In this case, the teaching physician can themselves document their presence during the key or critical portions, or the resident may document the presence during the key or critical portions. So the resident may dictate the entire operative note, and at the end of the operative note say, Dr. Smith was present for the key portions of this procedure. Or the attending can document their own note and state that he or she was present for the key portions of the procedure. I highly recommend that regardless of who documents the note, the resident or the teaching physician, especially on OR cases, that you always document that the attending was present, regardless of if the attending is documenting the note themselves or not. For endoscopy services, the teaching physician must be present for the entire viewing and must document this presence. Again, the difference here is that the teaching physician must document the presence themselves. The presence of the teaching physician cannot be documented by the resident or the fellow. For interpretation of diagnostic radiology and other diagnostic testing, if a resident prepares and signs the interpretation, the teaching physician must indicate that he or she personally reviewed the image and the resident's interpretation and either agrees with it or edits the findings. Again, for this service, it is up to the teaching physician to document their review of the test. So when you look at all of these different scenarios, the only one that's different and who's responsible for documenting the presence and participation of the teaching physician is surgical services. So again, for surgical services, the presence and participation of the teaching physician can be documented by the resident or fellow. However, for E&M services, endoscopy services, and diagnostic radiology or other diagnostic testing, the attestation must be documented personally by the attending. So let's take a look at some different teaching physician guidelines, especially E&M documentation scenarios. So for scenario number 1, the resident performs and documents the elements for an E&M service jointly or in the presence of the teaching physician. In this case, the teaching physician must document that he or she was present for the key critical portions and was personally involved in care of the patient. The teaching physician note must reference the resident's note. That's key for all of the different scenarios that we're going to look at. The teaching physician's note must always directly reference that resident or fellow's note or be linked directly to that resident or fellow note. So for this scenario, the key thing here is that the teaching physician to document that he or she was present for the key or critical portions and was personally involved. Scenario number 2. The resident performs some or all of the required elements of the service in the absence of the teaching physician and documents his or her service. The teaching physician independently performs the critical or key portions of the service with or without the resident present and, as appropriate, discusses the case with the resident. In this case, the teaching physician must document that he or she personally saw the patient, personally performed critical or key portions of the service, and participated in the management of the patient. The teaching physician note must reference the resident's note. So again, the teaching physician must document that he or she personally saw and participated in the patient's care. The key is always going to be personally saw and participated in the care of the patient, regardless of all the different scenarios. For scenario 3, the resident admits a patient late at night and the teaching physician does not see the patient until the next calendar day. The teaching physician must document that he or she personally saw and participated in the management of the patient. The teaching physician may reference the resident's note in lieu of redocumenting the entire note. In this case, the teaching physician's note must reference changes in the patient's condition and clinical course of treatment, and the date of service that will ultimately be reported on the teaching physician's charge will be the date that he or she, being the teaching physician, personally saw the patient and contributed to the overall care of the patient. So in this case, the resident admitted the patient the previous day, late at night, let's say 11 p.m., did the H&P around that time. The attending comes in and rounds on the patient the next morning. So the date of service on this claim is actually going to be the next morning, or the date that the attending physician had the face-to-face visit with the patient. So per CMS guidelines, the following are examples of minimally acceptable statements that will support billing for teaching physician services. I performed a history and physical exam of the patient and discussed his management with the resident. I reviewed the resident's note and agree with the documented findings and plan of care. Key thing here, the physician personally performed the history and physical. Because they personally performed the history and physical, it is safe to assume that the physician had a face-to-face, medically necessary encounter with the patient. I was present with the resident during the history and exam. I discussed the case with the resident and agree with the findings and plan as documented in the resident's note. Again, the key here is that they were physically present during the key portions of that visit, the key portions being the history and exam. This means that they were present face-to-face with the patient and had a medically necessary interaction with the patient, therefore supporting billing for that service. I saw and evaluated the patient. I agree with the findings and the plan of care as documented in the resident's note. This is probably a very common statement that you see, and honestly, it is the minimally acceptable attestation that you can use for teaching physician services. Again, it says that I saw and evaluated the patient, meaning that the physician had or the attending had a face-to-face medically necessary encounter with that patient. And then similarly, you can say, I saw and examined the patient. I agree with the resident's note, except the heart murmur is louder, so I will obtain an echo to evaluate. So in this example, the physician shows that they personally examined the patient. They heard something that was different and not noted in the resident's note, and they're adding this additional documentation to the already completed resident note. So again, shows that the physician had a face-to-face encounter with the patient, and they're providing and contributing to the overall care of the patient. Try to stay away from the term seen and agree, because if you just say seen and agree, even though it's very similar to the last two statements, it's not enough. CMS doesn't like it. They don't accept it. So you definitely don't want to say see and agree. If you're in an application such as Epic, you need to create a smart phrase that will help you just plop in those teaching physician attestations directly into your note. And again, the minimally acceptable attestations you can use would be the last two that you see here on this slide. And then finally, for teaching physician guidelines, don't forget the modifier. If you remember in the CPT coding classifications module, I introduced you all to modifiers. And there is a modifier that needs to be reported when you are working with a teaching physician, and that's modifier GC. And that simply tells the insurance company, most oftentimes Medicare, that the teaching physician services met the requirements for presence during the key critical portions of the service. And just saying, hey, I saw this patient with a resident or fellow. The resident or fellow is documenting portions of this note. I was there during the key critical portions. I did my teaching physician duty. It just reminds the insurance companies that we are a teaching institution. I am a teaching provider, and it helps to keep the GME dollars coming into the system. So it's not going to impact overall reimbursement on the claim, but it is a quality reporting and informational reporting modifier, and it is important that you remember to add it when it is appropriate. So finally, let's wrap up and talk about the utilization of scribes. Scribes are becoming more commonplace today, and we're seeing physicians ask for scribes more and more. We're seeing more patients coming to the clinic, and we're trying to save more time and become more efficient and have better clinic throughput. And one of the ways you can do that is by bringing scribes into the clinic. They're going to save time in a busy clinic, but keep in mind that there are certain requirements that have to be met when utilizing scribes. And the first and foremost thing is that scribes can only scribe. They cannot have other duties while acting in the capacity of a scribe. So this means that they can't be putting orders into the system. They can't be seeing patients, treating patients, vitaling patients, all of those things. Although you can utilize a PA or other staff member as a scribe, you still can't utilize them to do all of that additional work. So they can't be giving immunizations, they can't be prepping joint injections, things like that. Again, scribes are doing just that. They are scribing. They are dictating word for word or typing in word for word what you were saying with that patient during that encounter. So one of the recommendations I have here is utilize medical students as scribes. So medical students are going to be looking for opportunities to continue learning outside of their coursework and their internships and things like that. So a medical student is probably one of the best scribes that you can have, and it's a win-win for both parties. The medical student can come in and act as a scribe and learn at the same time. So they're doing a service for you, and they're also learning at the same time. And of course, they'll be learning or earning a little extra cash while they're at it. But don't utilize PAs or NPs for scribes because number one, they're overly paid scribes, and that's not the best use of their skill set. And even with your MAs and RNs, you shouldn't be utilizing them as scribes either, because they can actually be seeing other patients and doing things like blood pressure checks, immunizations, they can be administering medications, things like that. So you want to make sure that you are truly utilizing the correct skill set for the duties throughout the clinic. There are some documentation requirements that you have to keep in mind with scribes as well. The note must clearly indicate who performed the service and who recorded the service. It also must include the qualification of each person, such as professional degree or medical title, must be signed and dated by both the physician and the scribe. So the example scribe statements that I have here on this slide are actually pulled directly from the CMS regulations as it relates to scribe services. So honestly, take this down, use these statements word for word as you see them, just change the names. So typically what I will see in the beginning of a note is an opening by the scribe that says, I, Jane Smith, am scribing for and in the presence of Dr. John Doe. They do the documentation, you get your history, your exam, your assessment and plan. The physician will then get that note. They will review everything that has been scribed by their scribe, and they will attest to the following. I, Dr. John Doe, have personally performed the services described in this documentation as scribed by Jane Smith Scribe in my presence, and it is both accurate and complete. Please, I recommend just grab these two statements and use these because you know you're going to have every requirement that you need to support scribe services. So that concludes this portion of utilizing mid-level providers, teaching physicians, and scribes. If you have any questions, I hope that you jotted them down, and you can feel free to send me an email or we can talk about this during the live session. And again, I also have some references here. The teaching physician guidelines are a great reference that you can source to just elaborate on some of the guidelines that I've already presented to you. It is a really good reference. It is very easy to read, and it's a short reference as well, but it is there for you, so I highly recommend that you take a look at that. Thank you.